A very warm welcome to you and thank you for joining us on Health and Wellness. My name is Zaitun Ali and today I'm coming to you from the KTN Hospital. Joining me on set I have Dr. Tayo Opakunle, who is a medical officer under the Emergencies and Accidents Department. And today we are going to discuss about heart attack. Welcome on set.
Yes, thank you very much for having me.
Thank you also for having us right here at KTN Hospital.
Yes.
And today we want to talk about the heart attack.
Yes.
Let me start from the beginning. What is it exactly? How do we describe it?
Right. So a heart attack is when there's a sudden and abrupt blockage of the blood vessels that give the heart oxygen. And what it results in is that if the cells in the heart have been deprived of oxygen, what happens is they start to die. Yes, and so that essentially is what a heart attack is. It's a complication of having something known as coronary artery disease, which is where there are plaques or something known as atherosclerotic plaques that deposit themselves in the lining of a blood vessel, and eventually over time they can become unstable, and then when they rupture, they then cause a blockage within the blood vessel, giving the heart oxygen.
Okay.
Yes.
One could really ask, how do they even deposit themselves in the heart? Yeah.
So there are certain risk factors that put people at an increased likelihood of getting a heart attack. And usually it's associated with an increased risk of developing coronary atherosclerosis. So one of those main things, having hypertension, high blood pressure is one thing. Then another one is having type 2 diabetes is another major thing. Then there's also having elevated blood cholesterol, because if there's too much cholesterol circulating within the bloodstream, eventually it deposits itself in different arteries. Yes.
Okay, so cholesterol is a major component.
Yes, it's a very important component, such that if you were to go and have your cholesterol checked, if we saw that certain cholesterols were high, the key one being your total cholesterol and something known as LDL cholesterol, if we see that those two are very high, it puts you at an increased risk of atherosclerotic disease and eventually a heart attack.
Okay. And perhaps how can we now identify some of the symptoms that come along with this disease?
So before I actually talk about the heart attack itself, the symptoms that present when you're having a heart attack, what can happen is that there's something known as a precursor, which are symptoms that you can get before eventually you have a heart attack. So one of the very major things for us is something called angina. Angina is where when the arteries of the heart are slowly being blocked, when you get active and the heart has to pump some more, because of that blockage, it doesn't get as much blood as it needs at the time. And the thing is, the interesting thing with the heart is that the way the heart complains about not getting what it needs is with pain. So what will happen is, as this disease is getting worse over time in terms of the artery slowly being blocked, what happens is you might walk up some stairs and suddenly you're having a lot of pain in your chest, especially in the center of your chest. And then once you stop walking up the stairs and you sit down and rest a little bit, the pain goes away. That's a very, very important symptom that says, okay, something might be happening with the blood vessels of the heart that would be very important to look into. Usually a heart attack is something which there are lots of signs before it eventually happens.
It's progressive.
Yes, yes.
Okay.
But eventually what happens is that when you're having the actual heart attack, because what I was talking about there with the angina is because the heart is not getting enough oxygen when its level of activity is increased. But now with a heart attack, the blood vessels get blocked completely. Yes. And what starts to happen when you are having a heart attack, and it's a very classical description that patients give us. They'll say they feel a lot of pressure on their chest, right in the center. Some patients even describe it as if they feel like an elephant sat on their chest. Yeah. Whenever, as doctors, when we hear that, that instantly tells us, okay, we need to make sure this person's not having a heart attack. Then some of the other symptoms, when that acute blockage has occurred, that you can present with, is you can present with palpitations, which is where you can feel the physical sensation of your heart pumping. Then another very key thing is that you start to profusely sweat. If you start having chest pain and you're sweating a lot and you're not doing any physical activity, that's a very ominous sign that you're actually having a heart attack. Okay. Then other things can include dizziness, difficulty in breathing. Sometimes some people describe almost like a feeling of like heartburn or indigestion, just slightly below where the chest is. And then in worst case scenarios, what can actually happen is that you can lose consciousness temporarily, and in the absolute worst case scenario, your heart can actually stop.
Okay.
Yes.
And when this occurs, is there something, maybe let's say a first aid that people are taught to do before now taking the patient to the hospital? Yeah.
So if somebody is having a heart attack, the first thing is it's an emergency. So if you have access to ambulance services, that would be very good to call, such that they can arrive and transport the patient to a place where the patient can then be treated. But in the event that your heart actually does stop, it is very important that just the everyday person knows actually how to do CPR. And the major thing by this that I mean is what's known as chest compressions. Okay. Yes, where I'm sure you've seen in the movies where something happens and then they come and they start.
The mouth to mouth is the same thing.
Okay, that one for infectious disease purposes.
Okay.
Yes, that one is not advised.
But we've seen that when you try to resuscitate someone.
Yes.
That's what it's called?
So yes, it helps to resuscitate someone. But what that actually does when you're doing the chest compressions is by pushing directly on the heart, you're actually helping the heart that stopped to move blood around. Yes. And there have been studies that have shown that something known as bystander CPR has been shown to increase survival rates of cardiac arrest if it's initiated immediately.
Is there something that we do, especially as human beings, to cause it directly?
To cause
a heart attack?
So outside of disease conditions, which can be controlled to a certain extent, I would say one of the biggest risks for a heart attack is stress. If you work a very, very stressful job, and what usually happens is that with stress, there tends to be a lot of other bad habits that go with it. So the other very worrisome things that we really need to take care of with regards to what we can do to prevent getting the symptoms of a heart attack or having a heart attack. So yes, we can lower stress. And then the other thing is to avoid smoking cigarettes. Yes, because cigarette smoke has been shown to have a direct correlation with coronary atherosclerosis and the eventuality of a heart attack. Then another thing is a good diet. So if we are eating a diet that's high in processed foods, high in cholesterol especially, that increases our risk of getting a heart attack. And then a lack of exercise or a sedentary lifestyle is another thing which predisposes you to developing a heart attack.
Okay, Dr. T, let me ask, when I come and portray the symptoms that you've mentioned, what kind of tests do you do?
Okay. Yeah. So when you arrive at a hospital, if you're brought by an ambulance, immediately as you're brought into the emergency room, and we've heard what symptoms you've been having, such as pressure in the chest, difficulty in breathing, some palpitations. The first thing we'll do before we even draw any blood is something called an ECG, which stands for an electrocardiogram. And this is where we stick some electrodes on certain parts of the chest, And what that does is it looks at how the electricity in the heart is moving.
Okay.
So there's an example of what an ECG looks like here, where this is a normal ECG. So this person who had the ECG done maybe complained about some chest pain, and we needed to make sure they were not having a heart attack. So we did an ECG, and
Yeah.
we're seeing it's completely normal. But if there are certain things that us doctors will see on an ECG that will tell us, okay, this person is actually having a heart attack and we need to intervene right away. So yes, so the first thing would be an ECG. Then, as I was saying, when you're having a heart attack
Yeah.
and the cells of the heart have been deprived of oxygen, they start dying. And this is of course very serious. So as they're dying, what happens is they start to release certain substances into the blood. One of them, it's a very specific marker of injury of the muscles of the heart. It's called troponins.
Oh, yeah.
Yes.
Okay.
So together with some other tests just to check how other parts are functioning, we'll order something known as a troponin test. And if we see that the levels of the troponins are very high, that tells us, okay, most likely you're having a heart attack. The thing is, there are other things that can cause troponins to go high besides from a heart attack, but troponins are very, very specific for telling us something is going on with the heart. And then after that, the other thing that we'll do is we'll do something known as an echocardiogram. And what that is, you know the way when ladies are pregnant, they go and have an ultrasound to look at. So now, this is an ultrasound specifically for the heart. Yes.
Okay.
And what we'll see when an echocardiogram is done is because parts of the heart are dying because of the heart attack, they stop moving. And so when we do an echocardiogram, we'll actually see the parts of the heart that are not moving, or they're not moving as well. Yes. And when we put all of that evidence together, it tells us, okay, most likely this person is having a heart attack, and now we actually now need to deal with that.
And for this ECG, is there a point whereby you thought it was a heart attack and apparently it turned out not to be?
Yes.
And
yes.
how will it showcase itself there?
Oh, that is, it's slightly complicated because we have to talk about the intricacies of the ECG. But usually, because of how advanced the technology has become, these ECG machines, they have algorithms actually which can interpret the ECG for us.
Okay.
Although as doctors, we're trained ourselves to be able to look at the ECG regardless of the interpretation and know, okay, we're dealing with a heart attack here, or a part of the heart is not receiving as much oxygen, or the way the electricity is moving in the heart is abnormal.
Oh, so it can show a different condition happening maybe in the heart as well?
Yes, yes, it can.
Okay, and perhaps give us an example of a time whereby you've had to deal with a patient who's come in the emergency with a heart attack. How does that look like?
Right. So when we've diagnosed the heart attack by doing an echocardiogram, an electrocardiogram, and the troponins test, the first thing that we then do is we immediately call the cardiologist, because the cardiologist is the doctor that is the specialist that deals with all matters to do with the heart. Yes. So we give the cardiologist a call, and we'll discuss what we've discussed with the patient with the cardiologist. Then usually the first thing that we'll do is we'll give some medications immediately, which what that does is it makes the blockage in the heart slightly softer.
Okay.
So these are the medications that we'll give is something called aspirin, then something else called clopidogrel, and then something else called atorvastatin or a statin. What that does is, as the blockage is forming, when we give those medications, it essentially makes the blockage slightly softer, such that when we'll discuss the treatment for it now, when the interventions that need to be done to unblock that artery are to be done, it's a lot easier to do that.
Okay.
Yeah.
And I can see you also have your dummy, your heart
Yes.
dummy.
Yes.
So for this one today, you carried for what purposes? Actually, to show us how the blood is flowing, or
So,
for what purpose?
yes. So
Yeah.
this is what the heart looks like, not those love hearts that we used to draw as
Now
as
you've
kids.
killed our dreams. You know, I have
So
full hearts.
of course the heart is not this big. It's about the size of your fist. But this is just a bigger model, so it's easier to see things. So the heart has it has 4 chambers in it. There's a left side and a right side.
Yes.
And if you can see these lines here, so the red lines, these are arteries. So these are the blood vessels that give the heart muscle oxygen. And there are 3 major arteries that supply the heart. So there's what's known as the right coronary artery and the left coronary artery. But I said 3 because the left coronary artery then splits into 2 major branches that supply different areas of the heart.
Remind me where the aorta is. That's the only thing I can remember from my biology.
So
What's the aorta?
the aorta is the biggest blood vessel in the body that arises from the left side of the heart.
Okay.
So this structure over here, this is the aorta. Yeah. Okay. So all the blood that goes to give all of the tissues in the body oxygen, it arises from this point here. Yes.
Okay. What else from this model of yours can you
So
describe?
if I was just to demonstrate some more,
Yeah.
so the wonderful thing about this model is you can take it apart. So yes.
Let me hold.
So those are some major blood vessels that you're holding.
This is a aorta, whoever your primary school teacher was. And then this gray one is the?
That's known as the pulmonary artery.
Okay.
That's the artery that takes blood from the right side of the heart to the lungs.
Okay.
Yes, and then once the lungs have given it oxygen, it returns to the left side of the heart, and then the left side of the heart pumps it out through the aorta.
Okay.
Yes, and as I was saying, so if we were to cut somebody's heart in a cross section, this is what it would look like. So this section here is the right side of the heart. So this is known as the right atrium. Then in between the chambers of the heart, there are valves. So on the right side, this is the tricuspid valve. What it does is when blood is pumped from this chamber into this chamber, it prevents blood from this chamber coming back out.
Okay.
Yes. And then this chamber below is known as the right ventricle. Yes. And then this is now the left side of the heart. This is known as the left atrium here. Then this is the mitral valve. And then this is the left ventricle.
Yeah.
And if you look closely, this red over here signifies the muscle of the heart. So because the left side of the heart needs to pump blood to the whole body, it has to be a lot stronger. So if you look at how thick it is here versus how thick it is here.
There's a difference.
There's a very big difference, yeah.
Okay.
Yes.
Okay, so when someone has a heart attack, how does this look like now?
Right. So when somebody's having a heart attack, what will happen is all of this over here is muscle.
Okay.
So what starts happening is the muscle stops moving. It's either that it doesn't move as vigorously, or it stops moving completely, actually because it's dying or it's dead. Yes. So that's usually what happens when you're having a heart attack.
Okay.
Yeah.
Talking about now the treatment.
Yes.
How do we get to that after you've diagnosed and known that truly someone is having a heart attack? So what kind of treatment now do we get?
Yes. So the treatment for a heart attack, so it depends on the level of facility that you're in.
Okay.
Because if there are certain facilities available, how a patient with a heart attack is treated is different. So the treatment for a heart attack essentially involves unblocking the blood vessel that has been blocked.
Okay.
Yes. So we can do this either with medications, then with surgical procedures, either what's known as going to the cath lab for what we call percutaneous coronary intervention, or actual open heart surgery. Well, it's not open heart per se,
Yeah.
but they open your chest and then they deal with the blockage. So if I was to explain it from there, with regards to the medications, we can give medicines that essentially break up the clot that's forming in the heart.
Okay.
Yes, that would be at the most basic level. Then, in facilities that have what's known as a cath lab, what we do is when you present with a heart attack and we diagnose it, we'll then as soon as possible take you to the cath lab. Because in the cath lab, what they'll do is when the cardiologist comes to see you, they'll insert some wires that go into one of the arteries, either in the wrist or in the groin, and it goes all the way to the heart. And then through, I'd really call it the miracle of medicine, they're able to do certain things with those wires to unblock what's blocked, and then they put something called a stent to keep the blood vessel open. So those are the first two. And now in the most radical case, where when you have a heart attack and we take you to the cath lab, we look at how the arteries are. If we see that multiple blood vessels are blocked, so for example, if 2 out of 3, or actually all 3 of the blood vessels are blocked, then we'd recommend that you then go for something known as a coronary artery bypass graft surgery.
What?
Yes. And so this will then be done by the cardiothoracic surgeon. So if, once again, I was to use the model.
Yeah.
So with this red line here, and let's also use this one over here. Yes. So if we went to the cath lab and we saw that there was like a major blockage over here, that they weren't able to open up, either because the amount of damage is extensive or it's too dangerous to try to open it up. And then we saw like another blockage here. When we tell you that you need, so the abbreviation for coronary artery bypass graft surgery is, we call it CABG.
Oh, wow.
Yeah, CABG.
Okay.
Yeah. So when we tell you that you need a CABG procedure, what is done is that we take essentially blood vessels from different parts of your body, and what we'll do, or what the cardiothoracic surgeon will do, is, let's say the blockage is here. Essentially, the cardiothoracic surgeon will put the graft of the blood vessel before the blockage, and then connect it to after the blockage.
Okay.
So essentially, they've bypassed the blockage. Yeah.
Dr. T, you've mentioned a lot about the cath lab, and I think after the break, we'll be getting to see how it operates, and we'll have Dr. Jivanji with us. So don't go too far. We're taking a short commercial break, but we'll be back with more. This is Health and Wellness. Welcome back. If you're just joining us, remember this is Health and Wellness. My name is Zaitun Ali, and we're still here at the KTN Hospital. The topic of discussion is heart attack. Joining me right now is Dr. Hussein Jivanji, who is a cardiology fellow. And right here, he wants to show me what happens in this cath lab. It's called a cath lab.
It is.
And how the surgery goes on. And he'll help to interpret everything that we can see here. Welcome to the show.
Thank you so much. So, briefly, just behind you, we have the C-arm, the Philips C-arm, and which is the machine that helps us take the images or the photos of the patient's heart.
Yeah.
And the way God has created us is we have a left and a right coronary artery. So the left branches into two main vessels, which are basically the highways of the heart. And on the right, we have one big vessel. So like in front of us, we have a patient who came in with a heart attack. We did the coronary angiogram, and the process of doing the angiogram is actually, because we can't go in directly to the heart, we use one of the peripheral arteries, either in the hand or in the groin area, and put in a tubing, a plastic tubing, all the way into the heart, and then we engage the left, take images, and engage the right, and take images. Okay. So here we have the right coronary artery, and we took this image here, and we found that this patient had a significant stenosis, which means there is a blockage in the middle portion of his right coronary artery. So this patient was definitely having a heart attack. When we did the angiogram and we found the blockage, so the way to treat this in the cath lab is, because in the olden days they would use medications, but now we have the technology to put in a wire where the blockage is and then balloon it. So balloon means expanding the blockage, okay, and then putting in a stent, a metal stent, so that blockage never reoccurs. Yeah.
Oh, really?
Yeah.
So at this point, how long does this surgery take?
Yeah, so roughly the first procedure, which is called the angiogram, takes around 30 to 45 minutes. After that, depending on what we find, so we could get a normal angiogram so that the patient has normal coronary arteries or could have a blockage. And depending on the number of blockages and the extent of disease, we go on to do a procedure which is called a PCI, which stands for percutaneous coronary intervention. Or the patient could also undergo a surgery, a bypass surgery. But here behind us, what we usually do, and the way we intervene as cardiologists or interventional cardiologists, is by putting in a wire which we would call a percutaneous coronary intervention. So that procedure would probably take like another 1 hour.
Oh no.
Yeah.
And that currently, what is happening here as we can see it? What is really happening?
Yeah,
now once you started.
Yeah, so what happens is that, so this is the right coronary artery. Once we engage the right coronary artery, we inject a dye. So this dye enables us to take this image of the coronary artery, and it's not a still image like you can see, it's a video image. Yeah. So it plays, and then we can identify that there is a blockage in the middle portion of the coronary artery. And then once we have this, we discuss with the patient and the patient's relatives on the best way forward. And if everyone's agreeable, we intervene, we put in a wire, and then we open up the blockage. Yeah.
Is it the same image that you use as well when you're doing the surgery?
Yeah, so it's
the one that guides you?
Yeah, so it's the same image that we use, because it's the one that's going to guide us for the next procedure. Okay. When we're doing the next procedure, we're doing it on the same sitting, or sometimes situations don't allow us to do it on the same sitting, so we come back in after 2 or 3 days. But yes, we use the same image. Okay. And you can see that there are different angulations to it. So it's just like the camera and the way you angulate.
Different
so
angles
to it. Yeah.
That is. So at one point, at any given point, do you have to open up the heart?
So what we are looking at and what we do behind you here in this cath lab, we don't surgically open the heart, but we do what is known as maybe minimally invasive. So we use percutaneous intervention from the arm or the leg. But if it's an open heart surgery, then that's a different procedure. Yeah. So an open heart surgery would then be someone who has very extensive disease, probably someone who has blockages in all 3 vessels. So I've told you there is 1 on the right and 2 on the left. So if someone has blockages in all 3 vessels, something that's not amenable to ballooning and stenting, then we discuss a bypass or an open heart surgery with them.
Okay. Yeah. For someone who is coming to do this surgery, what are some of the basic things that they need to know in terms of preparing for this surgery? Yeah,
so I tell my patients like driving a car on our roads in Kenya, nothing comes without risk. So even this surgery has its own fair share of risks with it. So we usually discuss risks with the patient. It has less risks than going in for an open heart surgery, but there is risk of bleeding. So where we access where we put in the tubes and the wires, there is a small risk of bleeding. There's a risk of arrhythmias or irregular heart rhythms because we are going into the heart. There's a risk of stroke, and then the list of complications is endless, but almost 99% of the time, the procedure is quite safe.
Okay. Yeah. So aside from the risk, what else do they need to know? How long will it take? Should they eat something, not eat something, maybe those nitty-gritties? Yeah, so on the day of the procedure, of course, we'd expect them, of course, if they're coming in is an emergency, we take it as an emergency, so we just go with what is there. So if they've eaten, we'll still treat them. But if it's a routine
evaluation. So if you're doing a routine angiogram, then the patient has to have fasted for 6 hours, so not eaten anything from midnight if you're doing the procedure in the morning. So on an empty stomach, we do some baseline checks. So we check the hemoglobin, we check how thick or thin the blood is, because we don't want to encounter a scenario where we're doing this procedure and then the patient continues bleeding. So we need to ensure all those things are in check. So 1 or 2 blood tests are needed on the day of the procedure, and and we take consent. So of course consent means the patient needs to agree and sign a consent form.
Okay. Are there cases whereby a patient has come with a different complication, an underlying condition, other than the one that now you're treating, the heart attack?
So many a times a patient may be referred with chest pain, and then we're going in and we think, yes, this is a heart attack or this heart-related issues. But many a times we do the angiogram and we find it absolutely fine. So in that case, then we'd say that, look, the coronary arteries are not blocked, because that's what we are looking for in this case. And then try and exclude other causes of the patient's chest pain. And in that case, other causes would include maybe a clot in the lungs, which is a whole separate condition.
Oh, it's different
Yeah,
now.
it's different. And today I think we're discussing blockages in the heart, so heart attacks, It could even be acid reflux. Many patients, acid reflux presents as heart-related or chest pain, and then we'd end up thinking that, look, this is a heart attack, but sometimes we get a normal angiogram.
No, as you're talking about it, my heart is beating, literally. I don't know how you hack every single day doing this. It's really scary, but help us interpret this. We can see they are normal. That's the only thing I've seen. Something is normal here. What is it?
Yeah, so this is basically, so if you start on the top, of course, this is just a screen, just like any other screen, and so these are patient details. On the right of the screen, you see the image which is playing in front of you. On the bottom of the screen, you have the ECG gated, so that's the electrical activity of the heart. And on this
electrical
activity of the heart, so that's the ECG of the patient.
Okay.
So on this side, you just have because this is radiation, so it just tells you on how long you've exposed the patient to the X-ray, because this C-arm emits X-ray radiation, right?
Okay.
And how many minutes and what dosage, because one of the other complications with the older machines, of course, we had this exposure to radiation, skin burns and everything. I think with more modern machines, we don't get so much of those
so
complications.
these are modern ones.
Yeah.
What is recommended? What type of radiologies can now a person handle?
Yeah, so if you look at the American guidelines, I think they had a cutoff of around for around 50 mgy per second, but usually we try and keep the exposure down to a minimum.
Okay.
Yeah.
Okay.
On this side, then probably we have the waveforms. So this is the blood pressure monitoring of the patient.
Okay.
And these are some of the things we use to monitor if something's going wrong or if the pressure is damping, and we know that
Now
then
you
there
can
is a
see it
complication going to happen.
And the heartbeat as well?
And the heartbeat as well, yeah.
So this means everything is steady?
Yeah,
in case there's an alarm.
Yeah, so this is a flat line. The yellow and white lines are flat, because in this case we are not connected to a patient. So when we're connected to a patient, then you see the waveforms. Yeah.
Okay.
Yeah.
So when we see it like this, they're good.
It means then probably the catheter is not in the right place, or we've not yet gotten the pressure tracing. Yeah.
Okay. It makes sense. Now, after this surgery has been done, so post-surgery, what are the types of treatment and care that this patient should be undergoing?
Yeah. So after we do if we are going to treat the heart attack with an intervention, in this case the PCI or the percutaneous coronary intervention, then the first night usually the patient would spend in a cardiac ICU, which is known as a CCU, which is like an ICU, and then so that's close monitoring of the patient for the first night, and then the next night then the patient can go to a general ward, and from there can be discharged. So basically the patient stays in hospital for like roughly 48 to 72 hours. After that, then so on the day before discharge, we check the ECG again and check the kidney function, and then 1 week later we call the patient into the clinic where we when we run more tests on the ECG and we see how the patient is doing. 6 weeks down the line, we subject the patient to a stress test. So a stress test is where we put the patient on a treadmill machine and just make the heart exercise, and that really tells us if our intervention was successful. So if the patient is not having any chest pain, then we know that everything is going okay. Yeah.
And for this particular patient, how is he doing right now?
So this patient is doing quite well now. So we found the blockage, and then we decided to intervene. So we put in a wire and we opened up the blockage, and it was successful. And so the patient is doing quite well.
After the surgery, the wires are all removed?
Yeah, so after the surgery, everything comes out.
Okay.
The only thing the patient remains with is a small metal in the heart. It's called a stent.
Okay.
So that basically helps that artery remain patterned, so remain open, such that it doesn't block again in the future.
At least to allow the flow of blood.
To allow the flow of blood,
Okay.
yeah, where it was once blocked. And in this case, it's blocked by buildup of what we call cholesterol. Yeah. So of course, the other thing then we'll tell our patients is if there are any lifestyle changes they need to intervene, then they should.
They should.
Like if they're living a sedentary lifestyle, then they should probably exercise, and we encourage them to exercise. So cardiac rehabilitation is pretty big in these patients.
Okay.
If they're smoking, they need to stop smoking. We check the cholesterols, and all patients go on blood thinners and cholesterol medications. Yeah.
So they'll be on blood thinners for probably the rest of their lives?
Yeah, so these patients who had a heart attack use a blood thinner and a cholesterol lowering medication for the rest of their lives. Yeah.
Okay. Any side effects?
So usually what I personally prefer is not tell my patients side effects, because when you tell them that A, B, C, D is going to happen, then anything small that happens to them, they're going to say it's because of the drugs. So we let them be on the drugs, and then we monitor them closely, and we see if they're having any side effect. But no, generally what drugs we give them is what is used all over the world, and it's pretty safe. Yeah.
And I know so many people would like to know how intense is the pain,
for the
especially after the surgery, because I'm sure during the surgery they are under anesthesia, but after the surgery, so how can you manage the pain?
Yeah, so I think you've asked a good question, because we don't use for this intervention, we don't use any general anesthesia.
Oh, really?
So the patient is awake with us, talking to us throughout the procedure. Just the site where we're doing the procedure, we'll do local anesthesia. So that is it. But otherwise, the patient is totally awake. The pain is actually what brought the patient to the hospital. After that, once we've sorted this out, there's usually no pain. Yeah. So the patient remains pain-free, and that is actually our goal, because when we intervene, we want the patient to be pain-free, live a normal, healthy life.
Yeah.
Carry out day-to-day activities without experiencing any form of chest pain, because that then tells us that we've really succeeded in our intervention. Yeah.
Okay.
Yeah.
And moving forward, perhaps you can talk about the preventative measures that we can tell the people so that we don't end up here. So how can we prevent it?
Yeah, so it all comes down to a sedentary lifestyle. So we need to tell people to exercise more. And when I say exercise, it means more of aerobic exercises. So we recommend 30 to 45 minutes of daily moderate intensity aerobic exercise for most part of the week. So up to 3 to 5 days of the week. If you're smoking, you need to stop smoking. You need to have an annual medical checkup, which entails looking at your cholesterol, looking at if you have any diabetes, having your blood pressure checked. Because if you have blood pressure, then it should be well controlled. You should be on medications. If you have diabetes, it should be well controlled, and you should be on medication. So if you've actually done all this, then you can actually prevent a heart attack from happening. So you need to exercise. You need to watch your diet. You need to stop smoking if you're smoking. If you're diabetic, you need to start medication early. Or if you're pre-diabetic, you need to watch your diet. And if you're hypertensive, you need to be on medications and have your blood pressure in check.
Okay. Okay, that is well put and well said. Anything else that we've left out on this screen? Not really.
I don't think we've left anything out on the screen. Yeah. But basically, we get referrals from all over the country for heart attacks. That's because whatever setup you're looking at here is, we don't have a lot of centers having it currently in our country. But I think we are pretty much ahead compared to our neighbors in the East African community, because we still get a lot of across the border referrals as well. And I think this is the current best, most advanced way to treat heart attacks in the world right now.
Thank you so much for that, Dr. Jibanji. And I hope you've learned a few things here and there about now how the surgeries go, how the surgery takes place, and clearly the best part of it all, after it's done, clearly no pain. And thank you for joining us on Health and Wellness from the start until the end. My name is Zaitun Ali. In case you missed this episode, find it on YouTube at KTN Home. Also find us on our social media platforms on X at KTN Home _ at Zaitun Ali. And for Karen Hospital, where can people find you?
At the KTN Hospital, I work at the heart clinic on the 3rd floor.
Heart Clinic on the 3rd floor.
Karen
You're doing an amazing job. Thank you so much. Until next time, see you guys.